Hey guys, Don here. Welcome to the $1 Million Minute, where we're talking about how to get your practice to the $1 million mark and beyond. I'm going over the numbers here for a Wednesday. Once again, a little bit slower for me here, and this is the February numbers. We had 13 patients. So first patient was a 47-year-old. He had pain to the right ankle, so we did a right ankle injection for him. Office visit, and I'm going to do a 4-week follow-up to see how he is doing. Another patient was a EPAT number 5, and we kind of talked to him about the importance of an orthotic. We're going to scan him the next visit, and he also had a porokeratoma on the 5th med head, so we did a lesion destruction on that. Next patient, 79-year-old. This was an ulcer debridement patient, seeing them back in 1 month for ulcer follow-up. This patient was referred from a wound center in a neighboring city in Framingham, and I kind of said I think they were in the best place for that type of care. I do not cater much to wounds. I know they're probably very profitable for you that do them. We just don't do a lot of that in our office. Another patient was a 49-year-old patient for a nail avulsion, so level office visit with that. Another patient was a 66-year-old patient with another ulcer. He had an ulcer and fissure to the distal tip of the hallux. It's almost healed, not totally healed, but he did have almost like some verrucous changes on the side of the nail, and just like indurated, elevated, hard. And so I did 2 millimeter biopsies in that area, and I'm going to see him back in 2 weeks to go over that. I'm not sure exactly what it is. It might be a wart. It's kind of a weird place to have it, but we did that. Another patient came back in, 68-year-old female. This is one of those that I've been trying for these porokeratomas to do 2 millimeter punch biopsies, or kind of excisional biopsies with the punches. And she's back, has no pain. We'll see how long that lasts, if it lasts forever or if it comes back. Other patient was a EPAT number 3, 36-year-old female, feeling much better. She's going to be following up in 6 weeks. And another patient was she's doing all 6. So this is number 3 of 6. So I'm, as I mentioned before, I'm trying to go from 3 to 6 sessions. So I'm getting better at doing that. Another patient came in, 44-year-old female. She had functional hallux ligaments. And so the way I do that for patients, I show their big toe first MPJ moves. I kind of dorsiflex or push up plantarly on the first med head, and then I show that the jamming, and then I kind of preload the hallux, like showing what a Cluffy wedge would do, and then I kind of show the importance of an orthotic, how it jams, and how kind of like we can treat that. So I recommended anatomic shoes to start, and if that doesn't work, I was going to do an orthotic with a Cluffy wedge and a first ray cutout in that. Another patient is a 62-year-old female for EPAT number 1 for the Achilles, so we did that. Another patient, 46-year-old. This was a second opinion. He had a previous posterior heel spur removed from an orthopedist, or actually podiatrist that works in orthopedic practice. Never got rid of his insertional Achilles tendonitis. Still has swelling around there. And so he was kind of concerned. So this was like a perfect patient. This was like a second opinion, came in from his wife, another patient, and I teed him up for 6 sessions of Shockwave with at the ultrasound at the first, and at the second we're going to do an amniotic injection in there. And this is because of the chronic nature. It's been over a couple of years. It's just really not getting better for him. I saw his daughter as well, so she came in for Achilles tendonitis. She has really severe bilateral equinus, so we talked about focusing on that, and she also has pronation. I think part of her pronation is due to the tight Achilles, and she is abducting her foot when she walks and pronating to get more range of motion in the ankle. And so we talked about like night splint, foam rolling, morning stretch. She already has all that stuff, and then most likely orthotics at the next visit, maybe back to skilled physical therapy, which I ordered again for her, trying to avoid doing like a gastroc recession for her to lengthen the Achilles on a 17-year-old, and try to avoid doing that. Next patient was a 54-year-old female. This is a patient, she had a plantar fibroma. Now, I only noticed this on the ultrasound. So she had a fibroma, but it was not at the plantar medial heel, slightly distal, but I don't feel the bump. But I noticed it, and I did 3 sessions of Shockwave, and she was no better at 6 weeks out, like no better at all. And so in this case, I transitioned her to a cortisone injection. So I did an ultrasound-guided cortisone injection for her, and we'll see how she's doing after that. And then my last patient of the day was a patient with bilateral cariflex. So I did that for the patient. A couple of other things I was working on during the day. and I was talking to a friend about this, of like explaining things to patients, and he had this neat idea I wanted to share with you. He talked about there's two ways of treating symptoms. You can talk about fixing the symptoms, or you can fix the mechanics that cause the symptoms, like the underlying cause. And I kind of like that analogy, so fixing the symptoms or fixing the mechanics. And he talks about kind of an idea of if you have a leak in your basement, and then with a leak in the basement, you can either put a bucket underneath there and empty the bucket, and that's kind of fixing the symptoms, or you can fix the pipe that's leaking, and that's kind of fixing the mechanics. And so I think a lot of times in our treatments, we have certain treatments like the symptoms ones, like cortisone injections, contrast baths, icing, anti-inflammatories. Those fix the symptoms along with stretching, things like that. But like fixing the mechanics would be more like the Shockwave, Orthotics, sometimes even some physical therapy and things like that can help. So kind of designating and switching between those types of analogies might kind of work for you. If you guys have a really good analogy, let me know. One other analogy I heard, I was talking to one of my other colleagues, and we were talking about the fascia, the difference between fascia and tendon. And the way he kind of explained it is like fascia and tendon are basically the same thing, and they're the same as like ligaments. Under microscope, they look the same, just it's how they attach. So, fascia from bone to some, like under the soft tissue in the front of the foot, tendon from muscle into bone, and then ligament is from bone to bone. Kind of explaining it that way, teaching that way, and then kind of explaining how those are all white. And then I usually ask patients, do you think white things have good blood flow? And most people say, no, it would be red. And say, yeah. So that's why many times we have to help get more blood flow to the area because they are white. So if you guys have great wording techniques that work for you, I would love to hear them, and I will share them with other people. So just write them out, send me an email, don@podiatrypracticemastery.com, especially if you have a great one for orthotics that works for every patient. I'm trying to get better, and I want to help everyone else get better. So if you guys send it over, I will share it. And then lastly, if you guys like this, please like it or share it with other people, that this podcast can grow. Thanks.